Liz, thank you for this morning's information, and Megan Hyde, who's joined us as a speech pathologist. We've just been talking with Liz about eating and nutrition. We touched on appetite, we touched on a bit of swallowing, and that brought us to the topic of gastrostomies and PEG feeding. So really, can you tell me a little bit about what the process is of even contemplating going down the line of having a gastrostomy? Is this something that needs discussion?
I think it's a very complex decision that patients really struggle with. And I think in the motor neuron disease clinic, we now have realised that it's probably very important, not at the first appointment, but early on in the disease process, to introduce the idea that there may be issues in the longer term with swallowing or with weight loss. And it may be that some patients have actually presented already with weight loss and a degree of swallowing deterioration. So we are actually introducing the concept of gastrostomy feeding much quicker than perhaps we did in the past.
We don't wait until people need it before we discuss it. We often try to introduce it and introduce the patient to Liz, who can talk about what it looks like, how you might use it. We start talking about what progression of dysphagia might look like. We have Dr. Kopp, the gastroenterologist in our team, discuss the actual procedure. But our aim is to find out if people are interested in a PEG at all, and that might change over time depending on how their swallowing or their nutrition is, and we're open to people changing their minds. We don't want to feel like we're hassling them by asking at each appointment, but we do touch on it next appointment, even if they've said they're not interested.
Yeah.
But if somebody has told us that they do want a PEG, we don't want it to be crisis management.
No.
Where they needed it yesterday, and we can't get them in for a month for a planned admission because it's the middle of winter and there's an epidemic, a pandemic, and so we need to plan for it.
Right.
And I think there's a lot of misconceptions around gastrostomy feeding. People seem to think that it's all or nothing, that they have this tube put in, it's a foreign body. There's obviously body image issues as well, and a lot of them think, if I have this tube put in, one, it's an indication that I'm deteriorating. Two, I can't eat my normal food that I enjoy. In fact, we try to really deal with all these misconceptions from an early stage, that actually you can eat with a gastrostomy feeding tube, and in fact the whole benefit of a tube is that we use it to top up that oral nutrition. It also has the advantage that the medications can go down the tube, and of course patients really struggle with the swallowing aspect of tablets later in their disease process. We know from the literature that the big studies show that it's really important to have the tube put in early, and in fact they recommend that it should be in at a 5 to 10% weight loss.
Wow.
So the guidelines through the NICE Institute and through ProGas study, which is one of the biggest studies that occurred in the UK, recommend that we should really be placing these gastrostomy tubes early. And of course, that doesn't happen.
Patients are often not ready.
They're often not ready, and psychologically it takes a long time. Having said that, we have about 20 PEGs here at FMC, and probably about 4 of those are prophylactic PEGs. So these are patients that have elected to have their PEGs early when they're still eating and drinking normally, but they wanted to have the PEG in so it was there. They were relatively fit and healthy when they had it placed. There was no problems with their respiratory function. Whereas we have other patients who put it off and put it off and put it off. And obviously those patients don't tend to do so well.
Okay. So we need to look at whether they need a PEG from a nutritional perspective because of weight loss and appetite, whether they need it from a swallowing perspective for safety of from aspiration pneumonia or choking risk, or even just because they're dysphagic, they've had to change their diet, change what they're drinking, and they're not enjoying things as much. It can also be a huge effort to get through enough to eat and drink when it's hard work to chew, it's hard work to swallow. Eating a meal time's not something you necessarily look forward to. Or even if just
be a source of great stress.
Meal times are quite social. If you suddenly aren't eating the same food, or you can't have as much, or it doesn't look right, or you're coughing and spluttering, there's lots of reasons why somebody might still be able to eat but choose to have the PEG in early. And our preferred method is to have somebody eating and drinking and using the PEG.
So that's what you were saying, prophylactic application.
Yeah.
Or even supplementing.
Topping up.
Right.
But we do have a number of patients who are completely nil by mouth.
Okay.
Because their swallow is unsafe. And those patients would not be here. And these are patients, some of which are able to still walk along the beach, drive their cars. But obviously if they hadn't had the PEG put in, their lifespan would have been much shorter.
So it's a hugely important decision to be talking about early and moving on, almost is what you're saying.
And that's why Liz chose to look at putting together an app to help people with decision making and to put forward some of the perspectives of some of our patients who've come through the clinic and had a PEG.
So a decision making app to help a patient and their family work out the pros and cons of
but you can explain that better than
the
I can.
ifs and buts. That's really interesting.
So the app is actually a one-stop shop. It basically takes the patient right from the very beginning, the decision making. We have a seesaw that helps them with that decision, balancing the pros and cons. And then we have a number of the clinicians in the team also in the app. So for example, Dr. Koch, our gastroenterologist, takes the patient through what the procedure is, explains that. And we also have troubleshooting information and information about methods of feeding. So it really does take them through the whole process, and it's available for GPs or any allied health or patients and carers to access for that information.
So there will be a link on this GP's tool to that app so that they can possibly use those resources in helping them to get their clients to think about these topics as well.
Yeah.
So that's a great idea.
I know some patients who have communication difficulties or physical difficulties are quite anxious about coming into hospital for a PEG placement. So I guess that's another consideration for looking at a PEG earlier rather than later. But they also are very accommodating here, I'm sure at other hospitals, for people who need support person to stay with them during the admission.
Right.
So that's definitely an option, so people don't have to think that they're being abandoned by their full-time person who's at home with them who does a lot and understands what they need. They can sometimes come in.
Yes, they're probably their closest ally in knowing and yes, like you say, understanding what they're wanting and needing.
Physically pushing a buzzer or asking for help is not always easy.
No, it's not. So we've talked about diet and nutrition and weight loss. Are there any other symptoms that would promote the need to start thinking about gastrostomy and PEG feeding?
I think other than nutrition and dysphagia, so swallowing difficulties, the main reason we need to discuss it sooner rather than later might be respiratory compromise. So to undergo having a PEG put in, patients generally have an endoscopy procedure which requires sedative anaesthetic. if your respiratory function is compromised, that might mean that you're not able to undergo that sedation. So if there's concerns on that level, we'll liaise with the respiratory team, and anaesthetic review will take place. I know that there's some people who have been quite significantly compromised with respiratory issues who have still been able to have a gastrostomy placed. They sometimes consider RIG, so radiologically guided placement, and sometimes it's done in a surgical suite rather than endoscopy suite for extra close monitoring.
Radiological.
I was just thinking if surgical, if they do it, sometimes even with the endoscopy ones, they'll do it in surgery, or they might choose not to do it at the country regional hospitals because of the rest they won't choose to. So rather than at Mount Gambier, the patient might come up here and have it put in if there's some respiratory concerns.
So again, that's that you're talking about symptoms, so an overarching surveillance of these symptoms to try and make sure that the treatments and therapies that are employed have taken account of all of those things. So you've added again respiratory dysfunction as being a key.
Sometimes that's the reason they're referred to us as respiratory issues, not swallowing or nutrition. Because of that need to discuss.
And I think it is really important that we have the baseline respiratory measurements and the regular measurements, because again we know that from the research that patients do much better if their forced vital capacity is greater than 60% or greater. So again, it has an effect on survival.
Right.
So it really is a window of time with the respiratory function where we need to be thinking, we need to actually, if you're going to have a PEG, it needs to be within.
So you're talking about a window
of opportunity.
And you've got to be able to get through that. Yes. Okay.
For the best outcomes.
So talking about speech pathology, Megan, is a referral process, as Liz was explaining, simply a matter of picking up the telephone, or is there a form to refer for speech pathology? Would you come to to Flinders, or would you go local, as we were talking with nutrition?
I think going local is a good option for people, especially out in country, because I would much prefer that if there were changes that they could pick up the phone and say, can you come and see me, and they'd have an appointment within a week or two, than waiting to try and get back to Adelaide to see us in clinic. But generally, if someone's coming into the MND clinic and have any swallowing problems, we're very happy to be involved as well. And sometimes we're the only person who's involved, and sometimes we're working in conjunction with community. For us to see someone with swallowing difficulties through the MND clinic, we need a medical referral. So sometimes that will come straight from the neurologists because they've got concerns from our team, and sometimes that will come from a doctor or GP in the community, for example. I know a lot of people who are younger with MND, so under 65, will have National Disability Scheme, so NDIS funding, and they'll access private speech pathologists.
Right.
But in country, it seems that country health referral is a better bet.
The one-stop shop.
It's good, and it's a good way to have a dietitian and a speech pathologist who work together, and potentially an OT. Yeah. Often people who can come and see you at either a clinic that's close to you, or you can, or even at home sometimes, which is beautiful.
Great.
We are often the people, we might help inform that decision making and management in the community. So there's investigations that we can do here through Flinders that our country colleagues or might not be able to access easily. So we can help inform that decision making and planning. And also the PEG discussions are a big one that they often happen here rather than they might have touched on it in the community, but it's often a discussion where it happens through us, gastroenterology,
so
urology.
Kind of specialised conversation pieces.
I think it's somewhere it's easier for us to coordinate the necessary specialities, whether it's gastroenterology, respiratory, and obviously they see the neurologist at the same time, so we've got a very good idea about what the disease progression is, what the swallow is, what the respiratory function is, so it allows us to put that picture together much faster, probably.
And I think what we do find is there gets a point where people are having most of their nutrition through a PEG, maybe a little bit orally, and it's at that point it's often quite difficult to physically sit through multiple appointments in our clinic here, so it's often an afternoon by the time you've seen 3 or 4 different specialists.
And very often we'll do joint.
Might do a joint appointment, or I might
save,
say,
the patient having to go through things twice, and we're on the same.
We're asking similar questions sometimes about what they're eating, how much they're eating, how they're managing. But at that point we might say, you know what, you've got your speech pathologist in the community, do you still want to see us here, or are we at the point where you don't see us as an extra appointment and you come into clinic to see the neurologist, that you continue with that. So we sort of try and make sure that we cover the big picture stuff like the investigations and the PEG and often secretion management, and then once those sorts of things are either being managed through others or have got to the point where we're not able to add extra, then we try to reduce the load, because it's an exhausting process.
Seems pretty onerous.
Physically coming into the hospital can be hard work. The drive for a lot of people, and negotiating the roadworks and finding their way around a hospital, because often we're seeing people where they're not from the southern Adelaide area, so this is not a familiar hospital to them, and then they sit through 3 1-hour appointments. It's a long time, and by the time a lot of our swallowing patients are at the point where they're not eating very much, they're often struggling to communicate, so it's writing,
so they're getting pretty tired,
or it's typing and text to type on their phone to tell us what's going on, and that's really an arduous process for them and time consuming and effortful. So I think if someone can see you at home or see you where you're from and help support you, then that's sometimes a better option than coming into the hospital and seeing us once every 3 months.
The trip to Adelaide. Yes. Well, we've covered a lot this morning. Is there anything else that you would particularly like to convey to primary practice clinicians when they're caring for people with MND?
I think we've already covered it, but I think there's no harm in repeating that. I think early referral is important, and particularly with nutrition. There may be no swallowing difficulties, there may be no respiratory issues, but there is likely to be issues with appetite and weight loss, and therefore it's important to have that early referral process, because we know it does affect survival and quality of life and outcomes in terms of the decision around gastrostomy feeding in the longer term.
Well, we've talked at length today about nutrition and diet and gastrostomy, and the pros and cons of having one. What happens if somebody says, no, I don't want to have a gastrostomy? How do we deal with that?
Some people choose not to because they don't like the idea of something that they consider sort of unnatural, prolonging their life. And we try to help them manage that by keeping oral intake as safe and as comfortable as possible.
Okay.
So we try and modify food, modify fluids, so that what they are eating and drinking is comfortable for them and, if possible, safe. We sort of have to discuss sort of the concept of comfort feeding, which for some people isn't that comfortable, but they may choose to keep doing it. So some people might choose to have something that makes them cough and splutter every time they drink, but that's their choice, and we have to understand that. So it's not a matter of speech pathology saying you have to be nil by mouth. It's us trying to work out what works best and what's safest and what's most comfortable, and trying to maintain, where possible, as much nutrition as possible to reduce that discomfort from dehydration, malnutrition, constipation. Yeah.
I think it's important, obviously, to have that discussion up front, and probably at that time we would involve Peter Allcroft, our palliative care physician, who would discuss the benefits and the burdens of feeding, because essentially at the end of the day it comes down to the perception around what benefit is this going to be to me, or it may be for other reasons, religious reasons, they decide that they don't want to have a PEG. And I think, as Megan said, we will try to support the patient through the decision. It's their personal decision, and in fact, we just give them the information, and at the end of the day they're the only ones that can decide. With gastrostomy feeding, the advantage is it can be removed at any point.
Okay.
And so if people don't want to, if they go through the process and then decide that, no, this is not what I want, then it can be removed, or we simply just don't use it.
Okay.
So it's important that patients realise there are options, and they don't have to use it. It's very personal. It's probably a good idea to have that in their advanced care directive, to have these discussions early on with their family as well. And it may come to a point, we've had several patients who have been fed all along, but towards the end of the disease progression there's been a gentle weaning off the feed from via the PEG as the disease process has taken over, and again that needs to be done in a supportive environment with discussions with probably palliative care, to support the patient through that process.
So there is actually a process of withdrawal or withdrawing from the feeding that you might have been having, is what I'm hearing.
Yeah, as with the artificial
NIV.
So although there's no formal process, it's around a discussion because it's a very personal decision. But I think it's important that patients do know that they will be supported through that decision.
And does that often happen when other things might be starting to come into play, and a reduced energy anyway? As you say, you're talking towards the end of that disease process.
So towards the end of life care. Really.
So we're making the referrals
sort of
to palliative care.
into to palliative care process.
Good to know that there is committed clinicians out there to help people living with MND to maximise their quality of life and function for as long as possible. And it sounds like there are many therapies and opportunities to keep as well as you can for as long as you can. So thanks again for joining us this morning.